So we're going to quickly go over chapter 16 because we went through a lot of the information in chapter 16 and 15. So they go hand in hand. Your chapter 15 was your postpartum adaptations of the client, and chapter 16 is our nursing management. What should we do and how can we help this client transition safely through the postpartum period? See if I can make this a little louder. Okay. Can you guys hear me okay? I know there's a lot of background noise. I have everybody on my block is deciding to mow their lawn today.
Yes, we can hear you.
Okay, good. Okay, so we went through bonding and attachment, and there are certain aspects that differ bonding from attachment. So again, attachment cannot happen without bonding. Bonding is having a close attraction to a newborn by the parents, okay? This develops 30 to 60 minutes after birth, and it's unidirectional, so it's usually from the parent to the baby. And we can promote bonding through close proximity of the baby and the parent together. Attachment is the development of the strong affection that occurs from the result of bonding, okay? So this is what ties people together. This is how you're attached to your children, you're attached to your family member, right? You become attached to them because you develop a strong attachment and bond between each other. So nursing assessments during the postpartum period. So during the first hour, right after the birth of the baby, we want to assess our client every 15 minutes. Why do you think we're performing the vital signs so frequently?
So that if any change, you catching it very early.
Good. So I say this all the time. We are risk anticipators, right? So you need to anticipate the worst case scenario so that we are always prepared. So we're assessing it so frequently because we want to catch anything that tells us that there could be a deviation from the norm early and that we can intervene appropriately. The first one being is a possible shift in vital signs, right? So tachycardia, changes in blood pressure, and urinary output. All of these, and temperature, all of these things can tell us that there might be a problem. During the second hour, we're assessing every 30 minutes. During the first 24 hours, we should do vital signs every 4 hours. And then after 24 hours, this is a typo, it should be every 8 hours. So there's certain factors that increase a client or a female's risk for developing postpartum complications, right? So first and foremost, the best way to avoid postpartum complications would be for what?
In order to avoid it,
yes.
Know the respect, like know if she's at risk or not.
Okay, it's to know if she's at risk or not, but also just having an uncomplicated labor and birth process, right? So trying to avoid complications in the postpartum period happens as early as possible. And that's by facilitating an easy and gentle birth, okay? Anytime there is risk factors involved in the labor and delivery process or throughout pregnancy, there's a greater increase for complications in the postpartum period. So certain risk factors that happen during the delivery can impact or increase our client's risk. For example, operative procedures, right? So the use of forceps can increase our client's risk for hemorrhage. Any history of diabetes, preeclampsia, again, can potentiate problems in the postpartum period. if labor is prolonged, if she has anemia. So all of these factors can cause problems in the postpartum period. So our goal is to avoid problems at all. So we want to intervene as soon as possible or as soon as these problems are identified. So certain factors increase the likelihood or can be further characterized as to whether which risk factors they put the client at risk for. So for infection, it's operative procedures, but it can also fall under hemorrhage category. History of diabetes, we know anybody with diabetes is at greater risk for infection. The use of catheters, such as in a C-section, an indwelling catheter. You doing multiple vaginal examinations or frequent vaginal assessments during labor. Anytime there's prolonged rupture of membranes, increased risk for infection. History of STIs. So that's why we're swabbing our clients for any STIs. Or the manual extraction of the placenta. So this is usually being done during a C-section. So factors that can predispose our mother to hemorrhage, one of it is also being an operative procedure, a precipitous labor, so less than 3 hours, any problems with uterine functioning, so the uterine tone, problems with the placenta, our procedures, induction or augmentation of labor, our prolonged third stage of labor, so if it's lasting more than 30 minutes. So what's happening in the third stage of labor?
Placenta is being delivered.
Good, the placental delivery. So it shouldn't take more than 30 minutes. And what happens is that when it does take more than 30 minutes, there's generally a degree of something called placenta accreta associated with it. And that's where the placenta attaches so firmly to the myometrial wall, to the second layer of the myometrial wall, that when it becomes detached, it leaves little fragments in place. And that's what potentiates the hemorrhaging. Also, over distension of the uterus. We have a wide stretching of the uterine muscles, making it more difficult to contract post-delivery. So you'll see this with polyhydramnios or multiple babies or a large baby, a macrosomic baby. So danger signs, just like with any trimester, danger signs. Postpartum can also present with a lot of danger signs. So fever, anything of 100.4 or more. I am not worried about temperatures that are below 104. Why is that?
You mean 100.4?
Sorry, 100.4 or less.
Because the temperature does rise a little bit after the mom gives birth.
Good. So it's actually expected. So we do have a lot of diaphoresis and a shift in hemodynamic status that accounts for a slightly increase of body temperature and a shift of hormones. So I'm not worried for temperatures to be slightly elevated, but anything greater than 100.4 or more is telling me that there might be an underlying problem, such as an infection. Anytime we have foul smelling lochia, a change in color, so regression of color, large blood clots, saturating of peripads. So what would be considered as abnormal?
A pad saturated front to back in an hour.
Good. So front to back saturating more than an hour. Okay. So again, calf pain associated with dorsiflexion, visual changes, any swelling or discharge at the episiotomy site, dysuria, burning or incomplete emptying of the bladder, shortness of breath, difficulty bleeding, difficulty breathing, depression, or extreme mood swings. Okay. So unfortunately, the United States you might be looking at this and you're like, oh my God, this is common sense. Who wouldn't assess these mothers this frequently, or who would miss signs and symptoms of complications? The United States is still the leading cause of maternal deaths. I think we ranked number 4 or number 3. I don't remember our ranking this year, but it's up there in terms of maternal deaths, most commonly associated with maternal complications, the main one being hemorrhaging. We need to do better, I guess, in terms of helping our clients. So as the healthcare worker, you want to make sure that even though you might think to yourself, okay, I'm going to assess for all of these factors, but you also want to be keen on seeing any slight changes that can give you the inclination that there's something else going on. So pulse rate. Let's say I'm assessing my client every 4 hours or every 15 minutes, regardless of what it is, in the initial first postpartum day, right? I know that my client is bradycardic or should show a degree of bradycardia. So let's say for the first few hours, every time I'm assessing my client, my heart rate is 60, okay? And then later on throughout the day, I'm noticing that it's increasing to 80. It's still within normal range, right? But there's a sharp shift from her norm. So this should be in the back of my mind telling me, okay, I need to see what else is going on. I should check for uterine atony. I should check her pad counting. I should assess remainder of vital signs like blood pressure and take the whole picture into account. Okay, so just because you have levels within normal range, it shouldn't mean you should dismiss the changes, subtle changes right away. So just because your client is still having that change of blood pressure, it falls within normal range, but it's not their baseline, okay? Our pain goal. So our client's pain goal should be between a 0 and a 2 on a pain scale, depending on whether they had an operative delivery or not. Attaining a pain goal of zero might not be ideal or might not be realistic, but there's definitely pain medications and other alternative comfort measures that we could do to assist with this. So during the first 24 hours of postpartum, a slight elevation in temperature is considered normal, true or false?
Considered normal, true.
True, right? Okay. So bubbly, head to toe assessment. You went over this in clinical, correct?
Yep.
So you want to assess your clients from head to toe. You're going to start with the breasts. You're going to check the size, the contour. You're going to see if there's any engorgement. Generally, you won't see engorgement early on in the hospital setting. I have seen it with moms that have had 2 or 3 or 4 children before. But generally, with new moms, not very common that you'll see engorgement right away. You want to assess the uterus. So when you're assessing the uterus, what are you assessing for?
The fundus, to see if there's involutions happening.
Good. So we want to see if there's involution happening. We're also assessing for what?
Uterine atony, if it's present.
Good. Any uterine atony, how firm it is. Bladder, what are you assessing for?
Distension.
Fullness or distension.
Good. So distension. Oh, back to uterus. You're also assessing if it might be what?
If it's
Boggy or
Displaced.
displaced. Excellent. So I'm assessing if it's midline, how firm it is, and the height. Bladder. Also, I'm assessing if it's if the client is voiding, if there's bladder distension. Okay. How about bowels? What are you assessing for?
Bowel sounds.
Bowel sounds, any abdominal or bowel distension, the passing of gas, lochia, amount, color, and odor. Okay. the episiotomy in the perineum, any lacerations or hematoma or bulging. So a lot of times healthcare providers don't associate perineal trauma with any form of complications, but it can potentiate postpartum hemorrhage, especially with the perineal hematomas, because you have a site where blood is pooling, which can lead to postpartum hemorrhaging or concealed hemorrhaging in that area. What are we assessing the extremities for?
If possible, DVT. So for pain, calf pain.
Good. Calf pain. Anything else?
Yeah, warmth,
Warmth.
redness, swelling.
Good. Warmth, redness, swelling. Extremities. I am worried about DVTs, but I'm also worried about my extremities in my preeclamptic client, right? So depending on her degree of pitting edema, or with CHF or heart problems, it could tell me a lot about their condition. And how about the emotional status?
You're looking for like baby blues. So you're looking for like sadness, lack of interaction with the baby, lack of eye contact with the baby. Yeah.
So her emotional ability, her bonding, right? How she's adapting to it. Anything that might impact her emotional status. Okay.
Professor,
Yes.
so you said you can develop preeclampsia after, like in the postpartum period, right?
Yes.
So you already gave birth to the baby, and that was supposed to be the solution when you had it in pregnancy. So then what do you do it for postpartum?
Generally, in the postpartum period, it won't last more than 12 weeks. It will resolve. So what's happening is that a lot of times when the client develops preeclampsia in the postpartum period, it usually they had signs and symptoms. So remember, preeclampsia is a multi-system disorder, right? So they probably had signs and symptoms of preeclampsia in terms of how it affected their organ functioning, but not necessarily had been reflected in their blood pressure and their ketone levels in terms of their assessment. So usually they had some degree of it. It just wasn't so visually apparent in terms of assessment. What happens is that when they're delivering the baby, the body's adjusting. So the signs of preeclampsia can become slightly exasperated until the body compensates for that. And it generally won't last greater than 12 weeks postpartum.
Okay, thank you.
Mm-hmm. So the emotional assessment of our client, we want to see how they interact with their family, their level of independence. And you just want to be aware in terms of the emotional status in the postpartum period. Again, it's not going to be always in the hospital setting. We're only there for maximum of 3 days with the client. And a lot of individuals now are opting for something called early discharge, where they're getting discharged immediately after 24 hours. So being able to assess for all of these factors can be very difficult. So that's why ongoing assessment is needed in terms of their follow-up visits. And the hospitals now perform phone follow-up visits where they're calling 3 to 7 days after the client has been discharged. And this is the time where you can also screen for their emotional status. So you want to see how the client is interacting with the family, their level of independence, what their energy level is. So we know if they have a decreased energy level, it could be a few things. It could be their hemoglobin, their iron levels, but it could also be signs of postpartum depression.
I think there's like an affect, that the woman has on her face when you're depressed. It's
usually a very flat affect.
Yeah.
No emotional response. Okay. It's very difficult to fully understand the emotional status sometimes, but it's very hard to miss once you notice it. It's just a complete deviation from the norm. So Yes, I've seen clients that don't necessarily interact right away with their baby. They might not know how to bond yet. This usually happens again with adolescent clients or clients that have had first time babies. Clients that have actual psychiatric underlying disorder, their demeanor is completely different. The way their responses are, the way they interact, not just with the child, but also with the people around them, is also quite different. So it's kind of unmistakable when it does occur.
I have a question.
Sure.
What usually causes like postpartum depression? Is it like the hormones or just like the shock of not being pregnant anymore?
It could be caused by a lot of factors. Some of them, sometimes it's unknown, but hormones play a big role in it. Okay. Previous history of psychiatric mood disorders or depression disorders can also impact it. So they're more likely to develop postpartum depression. Okay. And I think something that's commonly overlooked is iron levels. So decrease in iron levels can actually contribute to postpartum depression if they're severely low. And I think that sometimes it's overlooked in the healthcare setting, or it's not given as high of a regard as in terms of being a cause sometimes. But I think a lot of clients that end up getting their iron levels corrected, generally their postpartum depression gets better. Again, this is nothing studied. This is just my observation.
I would think also the shift in thyroid levels, because
Yeah, absolutely. With underlying thyroid disease, also, if they have like hyperthyroidism, definitely these things can affect mood functioning, right? But a lot of times in the healthcare setting, they don't contribute or they don't tie things together. Okay, so that's where you come in as the nurse. You can help them make correlations between patterns. Okay, so we want to be alert for changes in mood. So irritability, crying episodes, when it becomes so severe, and anytime mom expresses feelings of hurting herself or the baby. And you also want to be very mindful. This is something I should have mentioned in the previous PowerPoints, of how you ask parents how they're coping, right? So a lot of times people already know that this period in the postpartum is supposed to be happy. They're supposed to feel joy. So they might not be completely honest with you with how they're feeling. Okay, so you want to be clued in on their demeanor, their responses. Okay.
can I ask you a question? Could you give us an example, like maybe if you ever had the experience of a mom who didn't directly tell you she was going to hurt the baby or herself, but did something else that told you she was in that state?
I didn't have this actual experience. But what happened, we had a client that was, she didn't say that she had any feelings of hurting the baby, but her demeanor was weird. She had a psychiatric consult also in the hospital. She had a history of having mood disorders or postpartum psychosis disorders in the past, right? She was getting treatment, but I don't think her medication was well enough. But when they were interacting, they were saying her level of interaction was off. She wouldn't make eye contact with the staff. Okay. She was very unaffected or like emotionally detached from anything. Okay. And for some time, she actually, she expressed feelings before she was going home of not wanting the baby. Okay. She didn't express the need to hurt the baby or anything, but I don't know if this was the same client though. There was another instance where we did have a client that showed all of these signs and they were slightly missed or dismissed. And unfortunately, I don't know exactly what happened. It's just alleged, but we had a client, the client's baby did die. We presume that the client tried to suffocate the baby. Again, they don't have any cameras in their room, so we don't really know. But when we were asking about what was happening, what was going on, the mom seemed very disengaged, disinterested. The nurse had went an hour in before. The baby was fine. It was a healthy newborn. So sometimes it can be dismissed.
And that's when you would call social worker, right?
Yes, absolutely. So usually whenever you're noticing these signs, it becomes a slippery slope. So always call. Well, if you're in doubt, always call for help, right? So even if they go get an evaluation, what's the worst that can happen? But not saying anything can be so much worse. So like in this instances, these nurses had this interaction with this parent. They noticed the odd reaction or the odd responses, and they brushed it off as, the person was just weird or different. They didn't really take it into account further. I would say, ever in doubt, always report.
Right. Okay. Thank you.
Okay, stages into parenthood: commitment, being attached to the baby, being committed to the baby, saying, okay, I know this is what I have to do. These are the certain things I have to give up in order to maintain or to promote a healthy relationship with my baby. Acquaintance, getting to know the baby, learning how to care for them. Physical restoration after birth for the mom. So moving toward a new normal. So this is kind of similar to the partner, right? Moving to a new normal, expectations versus reality, and then mastery. So achievement of parenthood or their parental role around 4 months. So the same factors that we mentioned in chapter 15 can affect attachment, and that includes the mom's cultural background, the baby's temperament, if they're separated from each other after birth, okay, and lack of support from staff. So disengagement. So what sort of teaching topics do you want to include in the postpartum period? So we know that we want the mom to heal and get better, and we also want to make sure there's safe transition of the baby to extrauterine life. So in order for the mom to heal, we want to manage pain and discomfort. So we're going to teach her pain relief methods, how often she could take her pain medication. If she had things like a C-section, of course, that's a surgical delivery. You want to teach her to splint. We want to do coughing, deep breathing, splint while coughing. Immunizations. So maternal immunization status. So this is where she could start getting her live attenuated vaccines again, such as her MMR. And this is also if she had gotten RhoGAM at about 28 weeks, she can get her RhoGAM 3 days in the postpartum period. Her nutrition is dependent on whether or not she's breastfeeding. Why?
Because if she's breastfeeding, she needs to take in more calories.
Good. So if she's breastfeeding, we want her to maintain her caloric intake, right? She was already pregnant. She was already consuming that extra 300 to 500 per day. So we want her to maintain that.
Sorry, just to clarify, she's not getting RhoGAM only based off of if she got it in the 7th month. She's getting it if the child's also
Yes.
positive. Okay. All right.
Yeah, also if they're positive. Okay. For clients that are not going to be breastfeeding, we want to teach them to not maintain their increase in caloric intake, but rather just focus on eating a nutritious, well-balanced meal. Activity and exercise is going to slowly be increased, but they can absolutely engage in physical activity such as light walking in the postpartum period, even in the first few days. Lactation. So generally what happens is a lot of moms will start off breastfeeding in the hospital, right? Because you have resources there. You have a lactation consultant. Some of the nurses can help you. But what happens when you go home? There's nobody there. There's a lot of lactating services that are available in the community setting. So it's important that when we're working in the hospital, we don't just teach them how to breastfeed, but we also provide them with continued support. We want to tell them the resources that are available in their community. A lot of hospitals now actually noted that there was a problem with this, and they have their own facilities in the communities to help mothers with lactation. They can also, the New York State Department of Health also has a lot of services for parents now and that want to breastfeed. And there's also a lactation line. So it's like a toll-free number where clients can call and get immediate breastfeeding support for any questions they might have.
Is there a lactation
So there's
consultant
actually,
that can come out to your house?
there used to be pre-corona.
Oh, okay.
There used to be a time where there was a lactation consultant, and either they would have sessions every day throughout the week at a certain location. But now it's just, unfortunately, either Zoom sessions or on the phone. So support actually has become very hard during the COVID pandemic for new moms, right? As healthcare providers, though, I think this is the area that we lack a lot in. So we know a lot of the information to teach them in the hospital, but we also need to be aware of what's out there in the community, and also to make sure we maximize their outcomes, their positive outcomes. So we want to be aware of, like the lactation services that are available in their community. Certain things such as they could have not Lamaze classes, but child classes in terms of how to care for the newborn. That could be very helpful to parents. Safety measures like CPR for the baby, choking management. All of these things can very much help the families in the community, and a lot of times they're free, so they're more likely to participate in them. Okay, discharge teaching, what they need to know at discharge. So most important, danger signs and follow-up care, when they should go see their provider, and when to contact in case of an emergency, or if they notice any certain signs and symptoms of an emergency. When they could resume sexual activity, and they should use contraception, especially if they're relying on the LAM method.
That's 6 weeks, right?
6 weeks, yes. 6 to 7 weeks. And if they need to use a form of contraception, even though the first period will be generally without ovulation, they should still use a form of contraceptives.
If they got the live vaccine, they can't get pregnant for 3 months, yeah?
Yeah, but that doesn't always happen.
Okay,
But they should not. We advise them not to. Okay. Providing care in the postpartum period. So providing care in the postpartum period is like providing any care to any client. We have to be aware of their cultural considerations. We want to promote their comfort level. Okay. Especially if they had a C-section or vaginal delivery, they're going to have a lot of discomfort either at the incision site or a lot of perineal discomfort. We could ask that, or we could teach them to use cold and heat applications. They have topical sprays and analgesics that assist in terms of pain relief. So they have a lidocaine spray that can help minimize the sensation of pain. We want to promote voiding, so increase the fluid intake. Asking your client, hey, I know you stated that you don't have to go to the bathroom. Let's just take a walk and try. Okay. So they might not tell you right away that they feel the sensation to void because they're going to have diminished sensation. But I'm telling you, 9 times out of 10, you're going to put them in that toilet. They're going to pee. Then they'll tell you, I didn't realize I had to go. It's not their fault. They just had too much anesthetics during delivery, and they used all of their muscles. Okay, promoting bowel elimination. Oh, if your client had a laceration or episiotomy, this is even more scarier than the actual birthing process. Okay, trying the idea of having to pass stool after having an episiotomy or a laceration can be very, very daunting. Okay, we want to make it as comfortable as possible for our client. So, providing them with a stool softener, teaching them about an increase of fiber intake and fluid intake.
What helped me a lot was the peri bottle.
Mm-hmm.
I felt like, I don't know, I just remember it being like so helpful.
Yeah, so using some water in the area or warm water actually very much helps with the relaxing of the muscles. But it can be very scary. Promoting activity. So we want them up and walking as soon as they're able to. And you want to be aware that there is a sharp shift in hemodynamic status, right? So the mom immediately in the postpartum period, we have to remember she lost all of that blood and fluid volume from the birth. So we don't want to just tell them get up and send them on their way. We want them to get up nice and slow. We want to take their blood pressure before getting up. We're going to ask them to dangle their feet. And somebody should always walk beside them early in the postpartum period for safety, right? So they just had analgesics during delivery. They're still a little bit woozy. They used a lot of their feet and pelvic floor muscles. So you really want to walk next to them and be very close by. Provide frequent rest periods. So some parents or some moms right after delivery, their walking can only go from the bathroom back to their bed, right? Anything further than that can cause them exhaustion. So we want to provide them with walking with frequent rest periods. Exercising, again, when they're able and ready to engaging in light exercise such as walking can be fine, and they could slowly start increasing their exercise regimen, like such as when they were pre-pregnant, as recommended. Generally at about 7 weeks, they could start resuming regular exercise, physical activity. Okay, so there could be a weakening of their pelvic floor muscles. So what are we going to recommend to them?
Kegel exercises.
Good, a lot of Kegel exercising, pelvic floor exercise. Early on, okay, they're going to be focused on the neonate. They're going to need a lot of support in meeting their needs. So they're going to need help with their self-care. We always, just like I said, they're pumped up on analgesics or anesthesia. They're on medications. So postpartum period, they're on NSAIDs in addition to oxycodone, PRN, so if needed. So we always want to ensure the client's safety. We never want to be far away from them. We want to teach them how to get up out of bed. So no abrupt movements. Everything should be nice and slow. And counseling about sexuality and contraceptives, when they can resume sexual activity and they need to use a method of contraception. They should avoid getting pregnant for at least 4 months. Promoting nutrition, just general recommendations, a nice, well-balanced meal, the increase to maintain of the caloric intake for breastfeeding clients, and then the supporting choice of the the feeding method for the newborn. So whether mom is breast and bottle or bottle feeding, we teach the parents the pros and cons of each, but it's really their decision. Okay, so again, I was telling you guys about all of these certain factors that the hospitals go for in terms of certification. So you have something called perinatal certification, you have something called baby-friendly designation, and a lot of times these hospitals get incentives for increasing their breastfeeding rates. So what happens with that is that some clients, some patients feel pressured by the healthcare staff, right? In order to breastfeed, or like they might not be doing a great job at parenthood if they're not breastfeeding. So we really want to be very mindful about how we're speaking to clients. And we're always supporting their decisions and never blaming. All of these things sound like common sense, but you'd be surprised what some people say to clients in real life. Okay, ensuring safety. We're going to check the blood pressure. Elevate the head of the bed for a few minutes. Have the client sit on the side. Dangle their feet. You're going to help them stand up. You're going to walk next to them. And you're going to frequently ask them how they feel and how their head feels, if they're feeling dizziness or lightheaded. Okay, a client who is not breastfeeding should increase her daily caloric intake.
No.
Nope. Good. Teaching about breast care, measures to alleviate breast engorgement. So breastfeeding. And if we have clients that are bottle feeding, ways that we can help with lactation suppression. So what did we say?
Take bra.
What else?
Cabbage.
Cabbage, ice to the breast. All of these things can be helpful. For breastfeeding clients, it's generally a little bit of the opposite. You want to use the ice or the cabbage after the feedings, warm compresses before feedings, and also a supportive bra, such as a lactation bra or a wireless bra.
I would think the wire would hold them up, like it would be helpful.
The wire can put pressure on the milk ducts in the breast.
Oh, okay.
This is for the lactating client. So it can cause engorgement also.
Mhm.
So promoting family adjustment and well-being, parental roles. I'm not going to talk about that again. We talked about it in detail. But sibling roles and grandparent roles. So sibling roles is really dependent on the age of the child or the age of the sibling. So younger siblings, I would say around ages 8 or below, can have some jealousy associated with a newborn. And there are ways that we can help dismantle the feelings of jealousy. So we can tell the parents to maybe buy a small gift to give the sibling at the labor. Okay, you want to include, the family can include the sibling in the plan of care. Okay, generally the older child has more of an understanding, and they could also be included in the plan of care, can actually do a little bit more than a younger child. And grandparent roles is also dependent on where they are in their lives. Are they retired? Are they still working? And their level of interaction with the newborn and the family. So you'll see in some cultures, the grandparents actually assume the complete role of the caregiver for the newborn, right? So the grandmother is usually doing a lot of the holding and a lot of the changing of the diaper and the bathing of the baby, and the mom is feeding the baby. Whereas some other cultures, the grandparents are more not as engaged, not that they're disengaged, but they generally leave that time frame or that gap for the parents to actually bond with the baby also. They don't want to intervene or impede on their bonding. So it's really dependent cultural wise and where the grandparent is in their life. Promoting bonding with parents. So again, having the partner engaged in the daily care of the baby, not just limiting them to diaper duty. So engaging them in maybe bathing the baby, doing skin to skin. So teaching about postpartum blues and postpartum depression. So we talked about the mood disorders, and typically they'll start peaking at about day 2 to 4, right? That's when you'll start noticing some of these signs and symptoms. So we want to teach clients, right, that this is not taboo. This is something that is a normal response to pregnancy in the postpartum period. It's nothing to be ashamed about. There should be no stigma surrounding it because we want them to get help as soon as possible, okay? We want them to teach them how often it should resolve. So it shouldn't last more than 10 days. And baby blues tend to happen for a few factors. So a lot of the hormonal shifts and the tiredness, right? So their parents are exhausted. So getting a good restorative sleep can be very beneficial in dealing with postpartum blues. And if it's not resolving, postpartum depression and psychosis are a lot more severe and they require referral to a professional. And we want to make sure that, again, we're teaching the mom the signs and symptoms of postpartum depression and psychosis, especially psychosis. If they're having any thoughts of suicide or any thoughts of hurting the baby, that this is not normal and they want to immediately seek care. And I think anything surrounding postpartum blues, postpartum depression, or psychosis, we really want to remove that stigma. A lot of cultures feel like it's embarrassing to report it or that they shouldn't be feeling this way. This is, so they're hiding it, and it makes it even more harder to cope. And it could actually make the symptoms even worse. So preparing for discharge, we want to make sure our client meets the criteria, provide immunizations if needed, ensuring follow-up care. So making sure the client attends their follow-up care, and we're also following up with them via the telephone after discharge, making sure they are followed up by their own healthcare provider, their own obstetrician and pediatrician, and home visit follow-up if needed. So back years ago, insurance companies would cover a visit from a healthcare provider to the home. Generally, it does not happen anymore. The only time you'll see a follow-up visit at the house is if there is a problem with the mom or the baby. So there are some challenges that are facing families after discharge. That's a lack of support, lack of resources, the need to resume work immediately, not having enough time off to make sure that they're healing and getting better. The shortened hospital stays again. So our hospital stays now are 24 to 72 hours. So we're discharging them early. And we're also bombarding the parents with all of this teaching and information. So it could be very overwhelming. And we might miss certain signs and symptoms of risk factors, right? So we want to do teaching surrounding danger signs. Okay. Any questions about chapter 16? Okay. Just hang on for a second. I just would like to see something. Okay, so wait, new share. On Monday, we will be doing chapter 22, 17, and 18. And then Wednesday on the 12th, we'll be completing the 23 and 24. I think some of you were asking me, I will post the blueprint for the final this week, okay? So that you get a head start on studying. And if you did not hand in any of your work, please do so as soon as possible. So this includes your prep U's that were due before on the dates of the exam. You will also have the last part of these prep U's that are due on the day of the final. Your ATI A and B should be submitted. And you also have your ATI Comprehensive Practice Exam A that needs remediations. So on the 17th, you have your ATI Maternal Newborn Comprehensive Exam. Okay, you do need remediations for that. You need a total of 3 remediations for that one that's due on the 17th after your exam, okay? Your proctored one. So you need 1 in each category. So you have your system disorder, your basic concept, and a medication.
I'm sorry, Professor. Can you repeat what remediations we need for the comprehensive?
So there's 2 separate ones, right? Your comprehensive one was open from the beginning of the semester. That's your practice one. There's 2 comprehensive. You have a maternal comprehensive and a comprehensive predictor exam. So which one are you asking about?
I think the practice one, the exam A.
That's the one that was open from the beginning of the semester, right? So it's not just maternity. It encompasses all of the med-surg and maternity and pediatrics. Okay, so that one you need your regular remediations, your 7 remediations. They could be in any topic. It doesn't have to be related to maternity.
The comprehensive one that we're taking with clinicals, who do we send the remediations to?
That you will send them to your clinical instructor.
Okay.
Okay. Your proctored one, your ATI proctored one, that's going to be on the 17th. Your remediations for that are going to be due at 11:59 on the 24th. So after your final by that night. And that's the one that you need 3 for. So it could be in any category also. And you just need 1 in each component. 1 system disorder, 1 basic concept, and 1 medication.
I have a question. So
Yes.
we have 3 more remediations to do. We have the ATI on the 17th. We have the one that's on the website that's been opened, and then we have to do one for the clinical that's on the 11th.
So I don't have, for the clinical, is your clinical instructor asking for it?
No.
No.
Then I don't need remediations for it.
Okay.
All right, so you only have two left, which is the ATI Comprehensive Predictor Practice Exam. That was the one that was open from the beginning of the semester. And then you have your ATI Maternal Proctored Exam, which will be on the 17th.
Okay, thank you.
Okay. So everybody's clear on that? Any questions?
I have a question.
Go ahead.
So, do you think it's possible for you to somehow go through the ATI that we're taking with you, the maternal ATI, the proctored one, and go through the topics and tell us if there's a topic that maybe we didn't go over in class that we should do on our own?
Sure, I can go through the components and we could actually do that on Monday.
Thank you.
Okay. Any other questions? Okay, so if you guys do have any questions, you can email me or text me via Remind, and I will see everybody on Monday.
I have just one more question. Sorry.
Sure.
Colostrum, does it also have protein?
It doesn't have as much protein as regular milk, but it does have some degree of protein.
Okay.
Not enough to keep the baby satisfied. So that's why when you're feeding colostrum, A lot of times moms will feel that they don't have enough milk, but the components are actually less. So there's less protein and fat content in colostrum, and there's more sugar and water content. So it's easily digested, and that's why the infant is hungry more frequently.
Okay, no, thank you. I just wanted to see if there was no fat and protein, or if there was, like you're saying, a lower level. Okay, perfect. Thank you so much.
All right, guys, any other questions or comments? All right, I'll see you guys on Monday. Enjoy the rest of your week.
Thank you.
Thank you, Professor.